We're really honored to have you all here as our first NOhep Medical Visionary meeting at AASLD. We launched this at EASL in April, and it was a tiny room. Christian was there. So it's really nice to see the movement growing, and we're really excited to have you all here and really highlight some of the work that the Medical Visionaries program has done so far. Just as a background, we started this in 2016. We started the NOhep movement in 2016 to go along with the WHO commitment to eliminate hepatitis by 2030. And as part of this, we launched a separate NOhep Medical Visionaries campaign to really highlight how physicians and providers and the medical community is really can lead the way to elimination. And we know it's going to take a real group effort from multiple stakeholders. And we think it's something that really us providers can own and step up to. And our goal is really been to highlight some of the very innovative ways that providers have been doing this. And we'll be doing that today. We try to squeeze as many great examples as we can, and there's so many more. So a lot of our discussion is really hoping to pull from you all some of what work you're doing or what work you know about that we can kind of use to show people, to showcase. And also, I think for many of us, hearing stories in settings like this makes us think in our own settings like, ooh, I could do that. Like talking to Carla, I never thought I might be working with people in the incarcerated setting, but I'm now working with our DOC. So it's just really interesting being able to cross-pollinate in a setting like this. So just housekeeping, if you haven't signed in, please sign in. If you haven't actually registered to be a NOhep Visionary, please go online and do that, because that way you'll get our emails and invitations to things like this. I want to introduce our World Hepatitis Alliance team real quick. Behind the camera is Chris. He's hard to miss. If you guys are coming, we're doing a flash mob today at 1:45. Look for him as we start gathering and setting everything up. I hope you all can make it. Jessica.
Will you repeat where the mob is?
Oh, the mob's going to be right in front of the convention center in the mall side, so inside. Michael Wingrove. It's too early. Michael Lindbergh, our president. Carrie, raise your hand. Carrie Jakes is our new CEO. Please come meet him when you get a chance. And Jessica is our head of programs, who has really been partnering with me on this program. So thank you so much. And we'll get started, right? We wanted to do intros, but we're really short on time, so please make a point of meeting everybody. And when we do the discussion, we'll have everybody introduce themselves too. So I'd like to invite our first speaker, Brian McMahon. Maybe just give everybody a little background of the work, where you work and what you've been doing. He's going to highlight his work in Africa.
Thanks. I'm Brian McMahon. I'm a hepatologist and I guess an epidemiologist. I've been working in Alaska since the early 1970s, and I run the biohepatitis and liver disease program at the Alaska Native Health Consortium, and we've been working on hepatitis B, C, and A, and we've actually reached the 2030 goals with hepatitis B probably a decade ago or more. But in addition to that, I got involved, I got asked by the CDC to get involved in a program in Africa on HIV and hepatitis B a decade ago. And then we actually finished that program and then started a program on monoinfection with hepatitis B. And the way that program got going is because people would go to the blood bank in Africa to donate blood, or at the hospital to donate blood, and they would find out, they would be tested for hepatitis B, hepatitis C, HIV, and syphilis. And if they had syphilis, they just bend over and take a shot, and that's that. That HIV got linked to the HIV program. If you had hepatitis B or C, they said, well, go to the hospital and see what they can do for you. And they went to the hospital, they said, we can't do anything for you. We don't know what to do. So we decided to get some funding through the CDC Foundation to start two model monoinfection clinics that follow the WHO guidelines and see how well they went. I was the co-chair of the WHO guideline committee in 2015, and so we wanted to see if we could implement those guidelines and train people on how to follow them and how well they would work. So I gave you all a handout, and so very briefly, the program was to establish two clinics of excellence that would implement the hepatitis B management and treatment programs in Nazi Mojo Hospital in Stone Town, Zanzibar. That was staffed by internal medicine and family physicians, and they had a lot of experience working in the HIV program, so they were experienced at managing chronic infectious diseases. The other one was in Mumbai in Dar es Salaam. That's the major medical school there, staffed by gastroenterologists and GI fellows. And we wanted to implement a model care and treatment program and then evaluate the feasibility and acceptability by patients, facilities, the government, and then look and see what was the outcome of that, looking at improvement in liver function tests and hepatitis B virus DNA, and also to train and increase the capacity of the healthcare workers to care for patients with chronic hepatitis B. So the project is from January 2017 to December 2021, and we're enrolling patients that are 18 and over, and most of the people are coming from the blood banks, but also from the hospitals and clinics. And we're only taking people with mono-infection, and that little recruitment guide just kind of shows you how we go through and pick out the select people who are going to be in it. So people that are eligible for treatment have APRI of greater than 1.5, elevated ALT that's 2 times the upper limit of normal, and an HBV DNA greater than 20,000, or one or more of the stigma of liver cirrhosis, which are listed in that little table there. So what are the results? Well, we have, our goal was to recruit 2,000 people. We recruited 2,052, so we stopped enrollment. And we are looking at how many of those patients had advanced fibrosis, and what was kind of shocking is that 257 of those patients met the criteria for advanced fibrosis. And we found 41 patients of hepatocellular carcinoma. And because the hospitals decided they wanted to do ultrasound in addition, although that wasn't part of the program, they do an ultrasound and they found 41 cases of HCC, which is a little bit on the tragic side because there's nothing they can do. They don't do surgery there. If you have money or if you have a connection with the government, they'll send you to India for a transplant, and you'll pay $80,000 for it, which is vaccinated a heck of a lot of kids for $80,000 at birth. And incidentally, by the way, they are not vaccinating children at birth in Tanzania or Zanzibar. And then they've already had 17 deaths from complications of hepatocellular carcinoma since we started. We found that 241 people met the treatment eligibility, and part of the program was to furnish them with TDF for forever. And 175 have already been started on treatment, and 4 patients that were started on treatment that had advanced disease expired. So we can see on that graph there that how many are enrolled at each of the sites and how many are treated. And you can see that we are really early in the project and we still have a lot of people that have to come back for their second, third, fourth, etc. visit. And the next thing are some graphs to show you that this is having an impact. So the first graph is just looking at the APRI scores, and the gray bar there is from Stonetown, Zanzibar, and the blue bar, the bluest, the lighter blue bar, is from Dar es Salaam. You can see that compared to people who weren't treated, who had a lower APRI, of course, because they didn't qualify, the APRI has really fallen. But more dramatically, as you look at ALT scores, in Zanzibar, the average ALT was between 200 and 250. That's really high. These are people who were asymptomatic that didn't know they had hepatitis B. And that ALT score has already dropped down on the 4th visit to the normal level. And the same with Zanzibar. With Dar es Salaam, it wasn't quite as high. It was 100, but it still dropped down by visit 5 to the normal level. And finally, the mean HBV DNA level. We are doing HBV DNAs at enrollment, and you can see impressively that in Zanzibar, the average level was, I can't even read that, I think it was 14 million, and it dropped down by visit 3 to close to non-detectable. And then in Dar es Salaam, it was 12 million. So this works very well. One thing we've learned is that I think 20,000 is too high. I think we should be using 2,000 because we found patients that had between 2,000 and 20,000 that had very high liver enzymes. And they were potentially going to get into trouble fairly quickly. So I think the WHO guideline needs to look carefully at lowering the cutoff to 2,000 and maybe making it a little more liberal for ALT instead of twice the upper limit of normal, maybe just an elevated ALT with the level of 2,000. We follow these patients every year, and so we'll keep tuned, and we'll give you more information later on. So.
Great. Thank you, Brian. So just as a kind of background as to why we picked certain cases, our theme really for this meeting is that we have the tools, the vaccines, the therapies, the cures, the care. We're not getting to the people that we need to. And that big gap is really what's keeping us from elimination. So our goal is how do we bridge that gap? All of us in this room are doing work to try to bridge that gap. So our message is how do we dismantle barriers to hepatitis elimination? You see the signage here, that's what our message will be during the flash mob. And so a lot of these cases are really talking about how do we get people access to diagnostics, treatment, cure, and the other big burden is personnel, right? What workforce will be doing this? And then finally, again, we'll have a couple cases about people talking about how providers can do advocacy in innovative ways to really bridge those gaps. So now I'm happy to bring up Homie Razavi to talk about a very innovative program he's doing in Uzbekistan, where you really do talk about diagnostics and access to treatment too.
Thank you, Sue. Thank you very much, everyone. I'm here to talk about the NOhep program, the Uzbekistan Hepatitis Elimination Pilot. And it's truly a pilot program for a national program. So we're not doing this as a demonstration project just to show that it can be done. It's really the precursor to screening 22 million people in Uzbekistan. These would be adults. The program is really focused on elimination of hepatitis B and C. It's one of the few of its kind, which is looking at both viruses. And as Sue mentioned, we have all the tools. We have the screening, we have the treatment for hepatitis B, we have the vaccines. And the fundamental question was, why is this not happening? We've been in this field since 2011, fairly actively since 2014. And what was surprising is we worked with about 98 countries, and about 10% of them are early adopters. So the Australias of the world, the Mongolia, the Egypt, they ran with it, right? So the question is, why is the other 90% not doing anything about it? And it really came down to financing. When you sit down with them, they said, look, we can't afford it. If we fund hepatitis, we're not funding something else. And the economic analyses don't work in these countries. Why? Because the majority of the payments are done by the patients. So when you show the governments, if you spend this amount of money, you'll save, they're like, we're not saving anything, actually. It's now we have to spend more money, and all it is deferment of payments the patients would have paid. The argument about loss of life falls on deaf ears. Yeah, people die every day. So the objective of this program is to say, look, we can actually do this without contribution, without financial contribution from the government. It's a catalytic investment. And so what we did is we bought the diagnostics, we bought the treatment, we provided education for primary care physicians, nurses, we provided the registry. So all the investment was done by us up front. Shipped all the products to Uzbekistan. And the trick is, the patients are still paying for treatment. Everybody in the country, so what we're doing is we're looking to screen 250,000 people in the capital city. Treat 20,000 Hep B patients, treat 16,000 Hep C patients. The screening for 250,000 people is free. All the laboratory tests is free of charge. What we've done is we've negotiated very low prices for the medicine. We increased the cost of the medicine to include the cost that we pay for the diagnostics and the laboratory test. And it's still 30 to 90% less than what the patients are paying in the private market to the pharmacies. Right? And so, as the patients pay for their bottles, the payments comes back to us. We buy the next batch, we ship it, and then the whole process. So the catalytic investment is a small investment up front that oils the pump, and once the pump keeps going, then it feeds itself actually. The full program will require about $3.8 million to screen and treat everyone, and that includes the payments by the patients. The catalytic investment requires about 1. So the ratio of about 1 to 4 you put up front. And the key thing is, at the end of the program, you get that funding back. You go to Ghana, you go to Nigeria, you go to Azerbaijan, and repeat the whole thing. And that's the beauty of the whole model. So no longer will be going to donors and asking for donation. We'll be we go and ask them for loans, because in about 5 years, we'll be able to actually pay back these loans for a national program, test and treat everyone. I'm going to pause there, and then when we have any questions, I'll be happy to discuss. Thank you.
Thompson from down under in Australia to talk about a nurse-led model of hepatitis care in prisons. And Alex is a hepatologist.
Thank you, Sue. And thanks for the invitation to speak today about our program. So in Australia, we have an epidemic of hepatitis C related to people who inject drugs, and we've treated the low-hanging fruit. So our clinic, the patients who are engaged in our clinics have now all been treated, and care really needs to move into the community to engage with people who won't come to the hospital. We have a big prison program in my state, so we have 8,000 prisoners in 14 prisons. Roughly half of prisoners have a history of injecting drug use and are in prison related to their injecting drug use, and about half of the prisoners with a history of injecting drug use are seropositive for hepatitis C. Before our program was started, prisoners would have to come to the hospital to access hepatitis C treatment. So if they were at one of the regional prisons, they would have to shift from a regional prison to the central prison, and from the central prison to the hospital to see me to access their hepatitis C treatment, which was very inefficient, and many prisoners would just refuse to come. So we have set up a decentralised nurse-led model of care in our state. So we have 2.5 full-time nurses, and they go out and they assess prisoners in their local prisons. They have a mobile fibre scan that they take with them. They follow a protocolised assessment process, and then they, using what we call a remote consultation, which is a very simple paper-based checkbox list, they identify prisoners who are suitable for treatment. And there are 3 hepatologists, so we have 0.2 EFT of hepatology support. We supervise the treatment. So we have evaluated the program to date. Amongst the first 400 prisoners, there were some interesting lessons learned. All of them had a history of injecting drug use. 90% of the prisoners were male. The 80% of the prisoners could start treatment without any doctor involvement at all. And only 20% needed to see one of us because they had advanced liver disease or they had a complex medical problem such as seizure medication that would potentially interfere with their hepatitis C treatment. Not surprisingly, the treatment is just as effective in prison as out of prison, so our cure rates are 95% within the prison system. We've now assessed more than 3,000 prisoners over the last 2 years. We've started treatment on more than 2,000 prisoners. And so it's a really successful way of engaging high numbers of people who are at risk of transmitting hepatitis C. So I think that's going to be one of the pillars that underpin our elimination effort in the state. So I'm happy to take any questions when we get to the discussion forum.
Great. Yeah, please write down any questions you have for any of our speakers. So what we're actually going to do is have all our speakers come first, and then we'll do the discussion. We'll have a longer discussion. I know we were going to discuss first. So I have Cami come up and talk about some of the really interesting things she's done here in the state of Massachusetts, actually. And she's had some ideas that I never would have thought about, like, oh, a doctor can do that. And so I'm really excited to hear what she has to share.
Well, what I want to talk about is how to work with your legislators. And one of the questions that people ask is, well, why do you need legislative support? Well, we found in Massachusetts back in 2013, 2014, when baby boomer testing was added to the risk-based screening with the CDC, was a lot of hospitals were like, we're prioritizing electronic medical record support, medical decision support for meaningful use and other ways of maximizing insurance payments. We don't actually care about things that would improve patient care, was basically what we were being told. And we found that when we passed a law that said you have to offer hepatitis C testing to everybody born from 1945 to 1965, suddenly doctors could go up to their IT people and say, this is a law. And they're like, oh, law? Well, I guess we need to prioritize it. So when we heard that USPFTF was considering expanding recommendations for testing to all adults age 18 and actually 18 to 79, which is awkward and is not going to be in our legislation. We immediately started putting together a legislative plan in Massachusetts. And so I just want to describe a little bit what that looks like. So we have a coalition called NOhep Massachusetts. We shamelessly stole it from San Francisco. We said we would fight them about it, and they were like, cool, we're California, you can take it. And so we're a coalition of doctors and other providers on the front line, lots of folks in the correction system, addiction medicine, and then housing advocates, people with lived experience. And so we put together the legislation, and then you do a congressional briefing. And we actually have this on the NOhep website if you want to see the YouTube video. I have the slides, and I'm happy to send it to NOhep if anybody wants to sort of replicate this in your area. And a congressional briefing is often congressional aides, but you know, if you come from a particular district, you can like make sure that those folks know that you're in the House. You know, they like to support their constituents. And we described what was happening in Massachusetts. States don't care about national. They're like, yeah, that's Mississippi, who cares? But they want to see what's happening in Massachusetts. So we cut very fine data. I actually showed data from Framingham, that's the town I live in, you know, showing a substantial increase in acute hepatitis C in our youth, describing the opioid epidemic. And then, okay, so that got everybody's attention. We got good congressional support for the state level. And then recently, I went to testify and supported this bill with the public health subsection that needs to vote it out for the full congressional approval. And there I basically said, here's what happened with the baby boomer testing law. We've tested most of our baby boomers. I bet this real deaconess, at this point, you know, 2/3 of our testing already is in the youth, and most of our new cases are already in the youth. So we're doing this without support, you know, but this is why legislation helps. And that's really important for your legislators to understand the difference they make clinically. And so if you're a provider on the front lines, you give a real sense of what it is they are helping you accomplish that they often don't see. And so we're now in the process of still trying to pass that bill, but many of our hospitals are already actually changing our electronic program. We should go live in about a month with all adult testing at this hospital, because it becomes a virtuous cycle. Oh, they're going to change the law. I better go ahead and change my prompting. Is that good enough?
Yeah.
Okay.
She also met with their state Medicaid formulary panel, I guess, and was able to change that. So I think that's a really important way of changing things as well. All right, so lastly but not least, Dr. Trooskin is going to talk about a provider network that NBHR, advocacy network at NBHR is starting up, and we look forward to working with them on this too.
Good morning, everybody. Today I'm here to talk to you all about the National Viral Hepatitis Roundtable. NBHR, for those of you who don't know, is a coalition of over 500 stakeholders. NBHR has recently been sort of reimagined. It has a new home at HEP, the Hepatitis Education Project, and it will be located, though, and led by Lauren Canary. Lauren, where are you? Where she is?
Yes.
In Washington, D.C., so very close to the policymakers. And the work that I hope to assist NBHR with is really to essentially create more Cami Grahams, and impossible really, but to really try to support providers to do some of the work that you heard her describe. I know providers are really busy, but we're actually natural advocates. We advocate for our patients all the time, whether it's a peer-to-peer or talking to a consultant and advocating for the care that you think the patient should or should not be receiving. And so I want to provide support to providers who think that they may not have enough time. And these are all simple things that we can do. We can speak with legislators, we can call our Medicaid directors and advocate for patients that we think may have been denied if they still live in a state with restrictions. what NBHR really is planning on doing is creating a sort of cachet of support systems. So we're going to create a network of providers. We used to do this on a more sort of loose basis. We would have a quarterly call, which for providers around the country was often difficult to put into their daily patient schedule. So we're going to create a Slack channel so we can communicate with each other in real time. There'll be a repository of draft legislation, of budgets to help with lawmakers and prison systems. There'll be all kinds of appeal letters and things like that that we can do to support providers so nobody has to reinvent the wheel. And most importantly, we want to connect you with each other and also with patient advocates. So NBHR recently had a patient summit and is starting to train patients as well to be advocates and give them the tools and the forum that they need so that their voices are heard. And if we can combine patients with providers, we believe that we can lead this charge to eliminate viral hepatitis, both B and C. And so what I'd encourage you all to do is to go to voices4, the number 4, hep.org, and let us know that you're interested. And we'll reach out to you all and start to bring you into this community. We also want to hear from you about what you feel you need. Alex?
So Brian, can I ask you a follow-up question about the treat-all concept for hepatitis B? Because in many parts of the world, and I'm sure in Africa, it's cheaper to treat than it is to monitor. And it also really simplifies the clinical algorithm, so it makes it much more accessible for primary care docs and nurses. If you diagnose hepatitis B, you start treatment. Probably makes it much simpler for the patients as well. So can I get your opinion about that and also how the governments in Africa would view that sort of economic justification for treating everyone?
Yeah, well, I think that, as part of the second question goes, the governments in Africa, one of the problems is I think a lot of the governments are waiting for somebody to come along with some money and help them do it. And this is what happened with the whole concept of the birth dose, which to me is one of the most frustrating things to try to work it. I've worked with Gavi, I've talked to Gavi and other organizations to try to get the birth dose in. And the governments don't want to do it because they're waiting for somebody to come along and do it when it's only like 20 cents. And then the authorities above are saying that we want to plan the birth dose. What the latest I've heard is Gavi wants to start in 2021. Well, if one person is dying of hepatitis B every 30 seconds, there's going to be a lot of people who are going to get infected between now and 2021. So my feeling that I've been trying to advocate is, why not start tomorrow with giving that birth dose to the children that are born in a hospital or a birthing center? That's 50% of the kids in Africa. And they could immediately drop that 30-second death down dramatically at a minimal cost. And I can't understand why the authorities on high are not advocating that. And that's one thing I think that maybe we should start pushing them to do and tell them, look, don't wait until you have a plan to implement birth dose nationwide for all those people who are born in and out of the hospital. Start within the hospital and work on your plan for out of the hospital. And do that tomorrow, don't do it next year or 2021. So I don't know if I answered your question or not, but that's sort of the feeling I have. I feel like I'm at the back end, and homie, we're both at the back end. The front end is the vaccine, and we should be really pushing that vaccine now to get it into the people that can access it immediately. Did I answer all your questions?
Yes.
But I say that the problem is the governments are waiting, and we've made the governments promise that they'll continue the programs when we're done, but only in those areas that we started. So it's not a nationwide thing.
So treatment and monitoring. I mean, that's an enormous gap. If they can't pay for a 20-cent vaccine, or if they're not willing to pay for a 20-cent vaccine, testing and monitoring programs are that's a bridge too far, I guess.
So just as a reminder, use this if you want to speak. Jordan, so
I just got to jump into that conversation, but I mean, I think the one thing that I think is important to consider with the treat-all strategies is who's paying for the treatment or monitoring. Because one of the big challenges is people people are, if they're paying for a treatment themselves in their pocket, even if it's relatively inexpensive, then the question of whether they, in quotes, need treatment, I think becomes really important. And that it's just important to really think through this. Like I am definitely, as you know, Alex, very in favor of the idea of exploring treat-all because of the simplification of it. But if people are being required to spend out-of-pocket money, which is often extremely limited, and they don't need treatment, then and that would be particularly for people, older people who maybe have very inactive disease, and you would argue that they need to be monitored, but the truth is maybe they don't. Like, I think we should be thinking about strategies, a way of identifying who actually needs monitoring as well, because we can get better at identifying who actually has a very good long-term prognosis and trying to develop some simple tools that might identify those people, because it's not a small burden to ask somebody to pay for treatment that they, even at $3 a month, that they might not need.
Tommy?
So when we talk treat-all, of course I'm going to speak out. So if we're going to put a man on the moon, we don't start with, what is our science today, what's the rocket, and will it get us to the moon? The answer is no, it won't get us to the moon. What you do is you work backward. You say, we're going to put a man on the moon, and we're going to work backward. What kind of rockets, what kind of ship, what kind of technology do we need to get there? What is known is that every 30 seconds people are dying. So what we do know is the current guidelines are not working. I think everybody can agree on that, right? That's the fact. Now, one hypothesis is a treat-all. So will that actually make a difference? My recommendation is to work backward. If we're going to have a treat-all, what is the evidence that we need in order to demonstrate? Because as we have these discussions, there's a lot of ideas about why it wouldn't work, the compliance, whether the patients would pay for it, the diagnostics. I completely get that. Let's build that evidence. Let's run those. But let's not assume that it's not going to work without actually putting it on the ground and actually doing it. So let's start with the hypothesis that, similar to HIV, everybody needs to be treated to control the viral load, because we don't know when they're going to go up, and they're not going to come back. And run the experiments and see. And if it comes back and says, look, 50% of the patients are dropping out, we have major flares, great. Now we have the evidence and we go backward in terms of the original guidelines and maybe loosen them down to 2,000. But the one thing is clear, we cannot start from where we are today and say, there's all sorts of reasons why we shouldn't go to treat-all. My argument is start with treat-all, work backward, and let's answer those questions as quickly as possible. Because people are dying every single day.
As a practicing hepatologist, I think there are a lot of Hep B patients that you can monitor and you're not hurting them. So I don't think treating all makes sense. I think the problem is the people who are dying are the people who are not identified and being evaluated for treatment and monitored correctly. So, when you're talking about money, to treat all financially, I think it's just out of control. And, there are some side effects to these medications. So we actually had a patient die of lactic acidosis from treatment of Hep B. And the big thing that we were thinking of, did this patient actually need to be treated? So, I've been doing this for 30 years and I have my own experience. I don't know what the other hepatologists say, but I have so many patients with Hep B who have not been treated, who are doing fine, or are being monitored closely. So I think that treating all is not the way to go. I think evaluating every patient and deciding who needs to be treated, and obviously everyone needs to be monitored, is the way to go. But I think the main problem we have is identifying all the patients who have Hep B who need to be considered for treatment.
Yeah, I think we all agree we need to find more people, and I think we all agree we need to screen more. Treat more, right? We all know that we're not treating a lot of, obviously liver cancer is still on the rise, so we know we need to treat more. And then we need to, flesh out, I think we really do need some good studies out there. We're really missing a lot of studies. All right, I saw Carol and then Christian.
Can I just ask one comment?
Okay.
So in terms of the monitoring, if 100 people get diagnosed and come to you, what percentage of them do you continue to monitor after 1 year, 5 years, 10 years?
All of them. They all get monitored.
In Africa?
No, I'm not in Africa.
Perfect.
I'm in the South Bronx, but no, I'm just kidding. I'm just saying that, they get monitored. So why can't we just monitor patients?
So 97% of all Hep B infections are in low and middle income countries. So you, our colleagues in Europe, are the outliers, right? These are communities that have access to diagnostics, they have access to healthcare system within a few hours, right? Now let's just take that model and then apply it to Africa, right? Where there's not even a PCR machine in the whole country of Chad, right? And now let's talk about how well those guidelines work. And the answer is they're not working. This is the issue.
But let's make the guidelines work then.
So let's just have a different discussion, which is hepatitis B and C have been treated as a liver disease. If we have this same discussion with infectious disease specialists, it's a viral infection. You have an antiviral, why don't you put them all on treatment? So this discussion is a lot easier with IDs than it is with hepatology. Because you look at it as a liver disease.
Debate now.
Sorry, we're going to stop.
Yeah. No, but this is the goal: is how do we process barriers in different settings?
Right.
And so Homie in his debate, which he had done on the Hep before, which we have to replicate at some point, just because it was such a good, vibrant discussion, talked about how having just a phrase at the end of the guidelines, in terms of, what did it say? Something about settings.
In settings where access to diagnostics is limited, we will allow countries to do test and treat all. So we will keep the current guidelines, just a sentence that says, look, if you don't have access to it, at least are allowed to consider test and treat.
So it's a good proposal. Wait, hold on. Did somebody's waiting. Yes, Carol, sorry.
So one of the problems, I think, as we're talking, we still get siloed, and I often wish that there was a thermometer that I could just stick in each patient, and I could test for HIV, HPV, and HCV. And then, my treatment and monitoring depends on what I find there, but I also can then work to either educate them on how you can stay HIV negative. If you're HCV, I can treat you, but are you going to be protected against getting B? And it's not enough for us just to be, going down into this narrow area where we're talking about testing and treating. I also want to talk about testing and preventing. And so, where is vaccination for, the majority, we talk about birth dose. Well, the reality is in so many countries, even when they get birth dose, they're getting the rest of the doses. But on top of that, if you look around the room at adults, and then if you go out into the community and look at adults, they're not protected against B. We don't have a C vaccine, obviously. We don't have an HIV vaccine, but I think we've got to bring vaccine into, it's got to be one of our tools.
Yes, and I would even say there's been, with this epidemic of Hep A in the U.S., that it's actually an opportunity for us to kind of bring up the discussion of Hep B as well and to incorporate that, because that's also a preventive strategy. And I don't know if the Hep A is even discussed at this meeting. I haven't seen anything, but it should, it's a hepatitis also. So I know it's 8 o'clock. If anybody needs to leave, feel free. We do have the room. If people want to continue discussion, maybe we'll do it for another 5-10 minutes. And then people can feel free to work or leave.
So Christian Ramers from the Clinton Health Access Initiative, and at the risk of getting political for the Clinton Foundation, so I sort of feel sometimes like we're a bunch of Democrats on stage just eating each other alive and having debates that are not going to be solved until we have more evidence, when we have very simple things to do. We need to grow our movement. We need to sort of get out there and use the tools that we have that work, like birth dose vaccine and like vaccinating adults and like DAAs. I'm really happy to announce that we've been able to work with the liver societies across the world, and we'll have a signing document that's a call to action today at 4:30, where we're actually going to have something that we can hold in our hands and take liver specialists around the world to task and say, why are you not more involved in this and why are you not more of an advocate? So Tachi Yamada has worked at Gates Foundation and is on the board of CHAI as well. He's going to give the President's Choice Lecture. Right after that, all of the 4 liver societies are going to sign this call to action. And I think we need to use it to grow this room much bigger than it is. We're all very active here, but we need a lot more help in the US and elsewhere to change policy and to bring in more money. PEPFAR from Global Fund, from other other funders to give us the fuel that we need to make a difference.
So I just wanted to add to the sort of specialist hepatologist conversation, because I agree that a hepatologist seeing a patient in front of them can monitor carefully and can institute treatment according to the guidelines when it's appropriate. But our challenge in Australia is I can't see everyone, and I can't see even a fraction of the patients. And so we need, in Australia, primary care doctors engaging with hepatitis B. And I think the current guidelines will always be too complicated for primary care doctors. I think they're just too challenging. And so at the public health level, it supports the test and treat all strategy.
Alex, can you talk a little bit about how Australia grew that? I mean, we all see the graph of that growing number of GPs that started taking on Hep C therapy. Was there a real training partnership? How did it happen? I heard also it was ID doctors driving it a little bit.
So we had really high diagnosis rates, and because of our epidemic, we had GPs who were very engaged with people who inject drugs, and so they've been the GPs who are driving the hepatitis C treatment. And so, curing hepatitis C is fun, and these doctors have big clinics full of patients with hepatitis C, so they really engaged early. And hepatitis C treatment is very easy. Let's be clear, you don't need a specialist to treat hepatitis C, you don't need a doctor to treat hepatitis C. The cost is an issue of the drugs. But if you take cost out of it, it's very simple. And so there was not a steep learning curve. Our sort of recommendation is that GPs should, when they're first starting, should treat in partnership with someone who's experienced in treating hepatitis C for 5 patients. And after that, they're skilled up and ready to go.
Right. Also, in addition to vaccination, I think, in addition to vaccination that I just talked about, the other thing that I think we can do is to try to put more encouragement, I don't want to say pressure, but encouragement on our HIV colleagues, because they've actually shown that they can manage chronic disease. Of course, they get this huge amount of money. We're not going to get this huge amount of money, but why can't we start piggybacking onto that program? So when they go out, like in Zanzibar, where I've been working, and they go out and they go to the nightclubs and they screen people there, and they go to the injecting drug places where there's needles and things like that, and they test for HIV. Why can't they test for Hep C and Hep B at the same time? And then link them to care. So we can ask our HIV partners to do testing and link people to care. And then my experience in Africa is that the HIV people that worked in the HIV programs have a lot of experience in managing chronic disease. It's not that difficult to manage chronic hepatitis B if somebody is trained, and they could do a more liberal treatment program, but also there could be a monitoring program for those people who are virus negative. A lot of my patients in Alaska are virus negative after many years, and treatment's not going to really help them. So they can monitor them every couple of years just with a viral load. It's less expensive than giving them 2 years of tenofovir. So there's a lot of different ways we can combine the best of the test and treat and the best of the monitoring of the patients. And we could try different scenarios in different countries, but I think we need the help of the HIV program to help us with this huge burden of hepatitis.
Great, thanks everybody. I think there's a lot that we want to jump from this, and I hope that we are able to have some future conversations. I definitely want to kind of feel like in terms of this whole statement that's happening with elimination, I think we do want to hold AASLD and all the other professional societies accountable, and I think that's where us pushing really helps. I know one of the messages is decentralizing care, and I was like, really? Hepatologists are going to get behind this? But if we're going to do something where we're really partnering with GPs, let's figure out how we're going to actually do that, because it doesn't happen in this room, it doesn't happen in this meeting, or we got to bring some primary care docs into this meeting, as I saw Australia did a good job of that too, training GPs at their elimination meeting and inviting them into the program. And we don't have any GPs here who otherwise are not really passionate about hepatitis like a few of us are. So anyway, I want to close this out. Thank you so much. Please sign in if you haven't already so that we do put you on our list. And flash mob today, 1:45, should be fun. We've got a Freddie Mercury, a little action going on today. So, hopefully it's not the last time we see you today. Thank you.